Okay. Yeah.
Okay, we would like to carry on our symposium. We'd like now to present my dear professor, Dr. Alaa Kandil. He's very well known and needs no more introduction. So we'll go on directly to the presentation. Please, Dr. Alaa, go on.
Okay. Thank you very much, Dr. Shadi, for this kind introduction. And I will be completing actually what Dr. Hazim was talking about, but in a little bit different way. I'll be talking about the so-called real-world experience. And what's that? Actually, just a very short introduction. We have three CD4/6 inhibitors, abema, palbo, ribo. Palbo and ribo have very similar structure, I'm sorry, with difference in abema and a little bit difference in the CD4/6 inhibition values. Okay, this is actually the difference in those levels. Palbo and ribo is given 3 weeks on, 1 week off, and abema has a continuous dose schedule. And we already seen from the data presented by Dr. Hazem that it's a very consistent effect among the three CD4/6 inhibitors, palbo, ribo, and abema, as you can see from the slide, with a very consistent objective response rate and progression-free survival, whether in the Paloma 3, Mona Lisa 3, and Monarch 2. You see actually this required progression-free survival. Okay,
Okay,
صوت كويس.
yes, carry on, Dr. Alaa.
Okay, so you have a hazard ratio of 0.5 nearly. That means that 50% of the patients do benefit with absolute benefit in terms of progression-free survival with nearly 7 months difference. And again, in terms of overall survival, though the hazard ratio is 0.8, but still you see another 7 months clearance between using palbo versus not using palbo in terms of overall survival. And this is very encouraging and a very consistent finding. So in terms of progression-free survival, you have 6.5, 7 months and 7 months among the three CD4/6 inhibitors. In terms of overall survival, you have 7, 8, 9 months in terms of difference in favor of CD4/6 inhibitors, as you can see. So that actually ensures us that this is a class effect rather than a coincidence. Okay, these are the data for the second line, fulvestrant with CD4/6 inhibitor. Again, very consistent data among the three CD4/6 inhibitors. Now, forget about the trials now, because why is that? Because the trials are trials. You're treating patients within a very strict environment, but we're talking about the clinic, about what are the data we have from our patients, okay? So clinical trials sometimes does not always correspond with the results from the clinical results. And this is very clinical trials. And this is very important. And why is that? Because clinical trials are conducted in a tightly controlled environment. It's not like the clinic, for instance, okay? So beyond the results of the randomized clinical trials of which guidelines are based, clinicians in daily practice encounter wide array of clinical presentation. As the questions actually that was directed to Professor Hazem beforehand, it's not always that you will find the exact eligibility criteria presented in the trial that you face in the clinic. Sometimes you have to work your clinical experience with the data. For all of the above, real-world studies are very important. This actually tells you exactly what's happening in the real world rather than in the clinical trials. So these are the major. أنا مش عارف هو في مشكلة في الصوت ولا أنا مسموع كويس.
واضح دكتور علي.
ألو؟
واضح دكتور علي، اتفضل.
بس أنا بيحصل عندي interruption anyway. Okay. So in the randomized clinical trial, we are measuring efficacy and safety. These trials are designed to show causality, randomize patients to treatment or comparator conducted in highly monitored control environment. This is very important. This is not the clinic. While in the real world observational studies, you're trying to measure effectiveness and safety, and you assess the patient reported outcomes and provide insight into the practice pattern. You need also to know how clinicians and oncologists are really practicing. Do they all stick to the prescribed dose, to the indication, to the eligibility criteria prescribed or described in the clinical trial? So actually it gives you an essence of what's really happening in the real world. And that's actually comes from the real world experience. So, for instance, it can also expand the approval that already been given by the FDA, for instance, from a clinical trial, like palbociclib was actually approved by the FDA via an expanded approval. It was only approved for women to start with. And the approval was based on data from electronic health records and post-marketing reports of the real world. Now the FDA is learning the feedback of the real world and expanding the approval from only women to receive palbociclib to men, which is very important actually. And that actually enlightens us about the importance and the magnitude of benefit we gain from the real world data. Okay, so this is actually the patterns of hormone responsive HER2 negative patients with metastatic breast cancer. You see in the left hand side, already Hazem and Dr. Iman discussed that very thoroughly. The practice actually showed that patients would be treated in 60% with endocrine therapy and 40% with chemotherapy. Now look at a more recent era, the year 2017, I guess it's even more now. 52% of the patients would receive CD4/6 regimens, another 30% would receive endocrine therapy, and only 13% would receive chemotherapy for patients with hormone responsive HER2 negative metastatic breast cancer with no visceral crisis. Okay, so what do we have? We have 4 major trials that we will go through one by one: the IRIS trial, the Flatiron trial, Polaris trial, and the expanded access program. 1, 2, and 4 are retrospective medical record review trials, and the Polaris trial is a prospective trial. So we'll start with the IRIS. But by the way, these results highlighting the pattern of palbociclib use in the real world and shows how palbociclib is effective and well correlated in the real world setting. This is the IRIS published in the JCO, December 2019, exactly 10 months from now. These are the study design. I will not go through all details. Conducted in the States, Argentina, and Germany. The data tells us the median age is very comparable. And actually, this is the disease site. Non-visceral disease was in the light blue and visceral disease in the dark blue. And this is the performance status among the 3 population from the 3 different countries, US, Argentina, and Germany. Again, this is the distribution of starting dose of palbo. Majority of patients could receive the prescribed dose, 125 milligrams, and a small percentage did have a dose reduction. And in Argentina, there was no dose reduction to 75 milligrams, only 200 milligrams in a small proportion of patients. And again, in Germany, it's more or less exactly like Argentina. And that would give us a little bit of the pattern of practice between the 3 different countries. Again, percentage of patients with dose adjustment of palbo, you see that actually in the States, no dose adjustment would needed in the majority of patients. Argentina, no dose adjustment in the majority. Germany would tell you the same. Now, rates of palbociclib in terms of progression-free survival in the United States, Argentina, and palbo fulvestrant with letrozole or AI and letrozole, very consistent between the 2 countries. Using fulvestrant in the US and Argentina is very consistent, though we don't have the 12 months data from Argentina with the use of palbo plus fulvestrant. But again, very consistent data with the use of aromatase inhibitors or with the use of fulvestrant in addition to the CD4/6 inhibitor Ibrance. Sorry. Again, in terms of overall survival as an endpoint, you see exactly the same between the US and Argentina, palbo and Argentina at different time points. But you don't have the 24 months overall survival data in the US and the 12 months overall survival data in Argentina. So the progression-free survival and overall survival rate in patients treated with palbo plus letrozole, the rates were estimated using Kaplan-Meier analysis at different time points, and the data are very assuring, whether in progression-free survival and overall survival. Now we come to the next trial, which is the Flatiron trial, which we're looking into the real-world progression-free survival months from the start of palbo plus letro or letrozole alone. Okay, and you have something which is very close to what have been seen in the clinical trials. Mind you that the same eligibility criteria was not exactly applied. It's not the same strict environment that we have in the clinical trial, but that was 0.68 hazard ratio, meaning 32% did improve having the difference. And again, the 7 months we already observed in the PALUMA trial was there in the median progression-free survival. RW refers to real-world progression-free survival. This is a new term, but it's a very important term. In terms of overall survival, a very consistent data, as you can see, between the use of palbo versus no palbo, either unadjusted analysis or the so-called PSM, which is the propensity score matching data, more or less the same. Now we come to the only prospective real-world trial, which is the Polaris trial. The Polaris trial included patients with hormone-responsive disease, HER2, advanced breast cancer, receiving palbo plus endocrine therapy, nearly 1,500 patients, only US and Canada, not other countries. And these are the key research questions to ask. What are the treatment patterns? We'd like to know how oncologists treat their patients using palbociclib, metastatic breast cancer treatment sequence, and other endpoints, with follow-up approximately about 3, and then a final reporting analysis would take place. This is really very nice because this is prospective data. The median age was about 64 years. You look at the percentage of the patients receiving palbo aromatase inhibitor at the first line, almost 50%. Palbo plus fulvestrant, 27%. 12% in the second line, palbo aromatase inhibitor, 15% palbo plus fulvestrant. And you now go to the recent other data, menopausal status, ECOG, disease sites, bone metastasis as first line. I mean, these are only descriptive analysis of the data you find. Now, come to the real world. How much or what was the percentage of patients that had dose modification? You see here that nearly almost 85 to 90% of the patients, either with aromatase inhibitor or with fulvestrant, did not need dose modification. And just going to 100 milligrams was a very small percentage, and nearly very, very minute number of patients did receive 75 milligrams. Now we come to dose interruptions. Again, at the Polaris, in the first line, compared to the PALUMA, which is the clinical trial, far less patients did not need dose adjustment. And this is very assuring to us. So they're telling us in the trial that 2/3 of the patients need dose modification. Actually, in the real world, when we see the patients in the clinic, we don't need that in more than 1/3 of the patients. And in terms of dose reduction, it was nearly the same. So, I'm sorry. In terms of adverse events, which really matters to us and matters to our patients, there was no real difference, as you can see. And this is almost a real world prospective analysis. Still, we're talking about PALUMA, less than the real world is less than the PALUMA. Leukopenia is less, anemia is less, and fatigue is less. So we are having enough data to tell us actually that we are practicing this drug in the real world data every day in the clinic. Even for the older patients, older than 70 years, using the so-called geriatric aid tool or the ADL, activity of daily life tool, you see that the patients at baseline and after 6 months was very comparable, and the functional status was preserved in this elderly population. So even in elderly population, you can safely use this medication. So the last one was the Palbo Expanded Access Program that opened September 2014, and this is actually before the approval of the Palbo. The Palbo was only approved in early the year 2005, and that the trial was ended when the Palbo was approved. So it's between September 2014 up to February 2015. These are 3 distinct observation periods. before and the treatment period it was observed, and the period after the expanded access program was there. Okay, so this actually tells us that the real world progression-free survival rate and overall survival rate, very encouraging and assuring data, whether in no prior lines or patient had already been subjected to first prior line or more than 2 prior lines, and the data are very consistent between progression-free survival and overall survival to assure us that we can use that. Now we come to the sequencing, as already been enlightened and mentioned in the presentation of Dr. Hazem, sequence of these CD46 inhibitors across lines of therapy. What about patients progressing after everolimus? In the real-world study cohort, we still experience objective response and stable disease in a very, very good percentage of patients, collectively speaking, from the expanded work. Now, the real-world evidence of similar efficacy of everolimus-based therapy without prior exposure of CD46 inhibitor tells us that there's no problem of using it, and then thereafter, as per the guidelines, there is the use of mTOR inhibitor and Afinitor. The problem actually comes from the Bolero-2 trial, that the eligibility criteria to use Bolero-2 and Afinitor is very strict. So, I mean, it's almost always in this area a very gray zone, and it's left to the physician decision and to the patient situation. Now, very shortly, these are more recent data that was published. This is in breast cancer, basic and clinical research. This is actually a retrospective observational trial, and this is from Netherlands. It's looking into all patients who received at least even one dose of palbociclib in this institute in Netherlands between September 1st, 2016 and April 1st, 2018, whose hormone responsive status was positive, HER2 negative, advanced or metastatic breast cancer, who had progressed on previous endocrine therapy. So they looked at the combination of palbo with any endocrine therapy that was accepted, which included fulvestrant and aromatase inhibitor. And this is a very clear observational trial. And their primary study outcomes were progression-free survival and the number of permanent treatment discontinuation before disease progression due to AA, adverse events. And you can see here, the dotted line is the real world one, real world curve, and the dark blue one is the palbo in the Paloma 3, and they are exactly matching. There's no difference whatsoever. So what's in the real world is there, and placebo plus fulvestrant is the lowest one, 1/7 more difficult patient, second line in the red one. So pretty assuring what they are telling us. So why is that? Because patients who met the eligibility criteria of Paloma are there, and those are the patients who did not meet the eligibility criteria. This is the one. This is actually why you have that. Okay? It's not because of the palbo does not have the same efficacy, but because you have to stick as much as possible to the eligibility criteria. If you stick, you're here. If you don't stick, you're there. So it's not like you. Yes, you have to always experience and manage the patient according to the clinical experience you have. But mind you, it's only 5 years. It's approved in the year 2005, the first palbo, first CD46 inhibitor, and now we're 2020. Yes, we do have some clinical experience, but still stick to the inclusion criteria prescribed in the different trials. This is actually what I just mentioned. And these are the conclusion. The effectiveness and tolerability of palbo in real-world clinical practice correspond well with the results obtained in the Paloma 3 clinical trial. Okay, this is another one, breast cancer, in February 2019. This is a retrospective single center audit. They are just looking into the charts of the patient. This is an audit. Hormone receptor positive metastatic breast cancer patients treated with palbo over a 6 months period in an Irish tertiary referral hospital. And their conclusion, that the compliance was good with existing CBC monitoring guidelines, and they observed an 11% incidence of venous thromboembolic event, which is significant more than the 2% prescribed in the Paloma 3 trial. This is ringing the bell. We have to be more careful. Yet, not everybody sees that. This is a institution audit, but we have to be more careful about that. Last but not least, this is examining the progression-free survival in the real-world use of Palbo in hormone-responsive metastatic breast cancer, published again in Oncology, July 2019. Again, this is a single center cohort review evaluated. You see, and that more and more institutions are doing trials to see the real-world data. This is between February 2015 and July 2017, and this is their conclusions. The real-world first-line Palbo produced outcomes similar to Paloma 2, with a median progression-free survival of 26.4 versus 24.8, despite more dose reductions and shorter time of first-time reductions. The median progression-free survival was the same, even with more dose reduction, might be to the little experience of the physicians, might be to the population subtype. They are complaining of a certain side effects more than others. However, but you have still the median progression-free survival the same, with no significant difference, and Palbo dose reductions may not significantly affect progression-free survival. This is the summary. Palbo has a large, broadly representative, evidence-based data with multiple real-world studies and outcomes with Palbo complement what has been demonstrated in clinical trials. Those adjustments of Palbo in real-world studies are as expected based on clinical trials experience. Sequencing is still an issue. So further, a systematic approach will likely be necessary to better identify the range of biomarkers. We still almost always, I was mentioning yesterday, need biomarkers to identify the patients who are most suitable to be treated with a certain drug under use. Thank you so much.
Thank you, Professor Alaa, for your excellent presentation. And the floor is open for any questions. Professor Gamal.
Dr. Alaa, thank you very much for your elegant presentation. I'm just asking about the role of Palbo, the second line now, in the view of the result from the last Antonio with Ziloda tablet compared to palbociclib that didn't show any difference in survival or progression-free survival. So what do you think that based on Paloma 2, Paloma 3, you can continue giving CDK4/6 or you can replace these by capecitabine?
Okay. Well, this is an excellent question, Dr. Gamal. طبعا أنا متشكر لحضرتك. But I think I will stick to the continuation of Palbo till I have more data. We cannot stop that actually like that. Especially, we've seen actually more than one trial and more than one real world data, which is actually what we're looking for, that proves the efficacy of Palbo in this subpopulation of patients. But I really like your question. It's a very important question, but time will tell about any further modifications that we need to do in the guidelines. Thank you, Dr. Gamal.